Good morning. This is Anna Davis from the Oregon Health Authority. It is 10:01. We're going to wait just a couple minutes before we get started on this hospital staffing webinar. Okay, we are going to wait one more minute before we get started. Good morning again. This is Anna Davis. I am the Hospital Staffing Acute Care Regulatory Manager at the Oregon Health Authority. And we are going to be presenting today on the investigation tools. So at this point, I will pass it to Kimberly.
Hello, I'm Kimberly Volker. I'm the Hospital Staffing Policy Analyst who oversees the investigations. I will say, just as we get started today with this webinar, it is being recorded and it will be posted on the OHA Hospital Staffing website underneath our Hospital Staffing videos page, which has our other webinars as well as our short videos that we make. We are doing a question and answer session. Go ahead and enter your questions at any time. That is going to be sent to the send questions here, and you can see that in all caps. And Tip just put the instructions on how to make sure that that goes to the right place. If you try to send your questions directly to me or Anna, we are presenting this this webinar about the investigation tools, and there is a good chance we won't see those questions during the webinar. So please do direct them to the send questions here, and Tip will help make sure that those questions get to us while we're presenting. So we will get started with the investigation tools. We can go on to our next slide. So Today, what we will be discussing is why we use the tools, the impact of tools on the investigation length, what those tools are, the tool resources, and then that question and answer session. And like all of our webinars, that is going to be a lot of time for this webinar. We'll make sure that we have a lot of time for you to ask those questions. So why we use the tools? We have been looking for opportunities to identify efficiencies to streamline the investigation process. And these tools have been designed in a way to allow us to reduce the need for follow-up to clarify documents, to reduce our requests for additional documents and interviews, and increase transparency in the investigation process. So to discuss a little bit more of what those mean, for reducing follow-up to clarify those documents, what we often saw when we are doing those investigations between September 1st, 2023, all the way up until June 1st of 2025, is that we'll receive these documents from the hospital, and what may be clear to the hospital, which makes sense because you live it, that this is your experience. Well, we receive those documents and we don't know those abbreviations. We don't know how the processes work at the hospital. So the tools are meant to streamline past that, to just get to the information that we need.
I'm going to jump in and say, one example is committee meeting minutes can seem really clear if you're reading them and you were in the meeting. If you weren't in that meeting and you don't know who all of these different participants are, and you don't know the abbreviations, it's really difficult to figure out what those meeting minutes mean, what happened at that time. And so we're looking for ways to cut down on us guessing at what happened and try to instead ask you to tell us in the language we can understand what happened.
Similarly, we might see a mismatch between the minutes and the roster for that committee, where maybe you've had a new member join the committee, or a member has left and someone's come on. Well, we don't, the roster wasn't updated, so it looks like we have someone who's a guest who shouldn't be voting and shouldn't be participating in this meeting, who's voting and participating. So that's another common example, I think, for the staffing level documents, the unit level, when we look to see, are you following your plan? A common example might be, we're looking at the timekeeping records to see when the staff member, let's say an RN, when the RN arrives, when they leave, to see, is everyone having their required ratios? Do we have the minimum numbers that this plan says? Timekeeping records say one thing, and then the charge logs that we're looking at to see who was assigned to the actual patients, they don't match. So we'll have someone who either is on the charge log, but we never got their timekeeping, or we have someone who's in the timekeeping, but we don't see them on the charge log. So we're trying to figure out, did someone float? Is this a nickname situation? And that requires additional follow-up, additional interviews.
And what I would say is, we understand that hospital staff are incredibly busy and there's a lot to do. And sometimes you don't make all the notes you want to make on the charge log. You get busy doing something else. We get that. The issue is, if we're then trying to reconstruct what happened, we're coming at it not having been there. So we have even less information than the folks who were there about what happened. And we are really guessing when we're looking at these documents. And we don't want to be in the position of guessing. We want to be in the position of looking at the best information you have about what happened at your facility.
And then also, to speak to the increased transparency in the investigation process, that's to address concerns we've heard from direct care staff about how do you know that the documents you get are really showing the full picture of that? So involving direct care is really our attempt to increase that transparency in the investigation process for all involved parties. And it mirrors that similar situation with the tools that we had in the previous nurse staffing surveys.
And again, that actually was a change from the original surveys that we started, the newest old surveys that we started in 2017. There were surveys before that and we had processes, but we built new tools in 2017 and we updated them in 2020 with the input of the Nurse Staffing Advisory Board to incorporate more direct care voices and to get that transparency as part of the process. And so when we were looking at building tools here, we looked to do the same thing.
So let's go on to the next slide. So the impact of tools on the investigation length. So we looked at the investigations that started on June 5th and June 10th. We have them in our sample size because by coincidence, it would seem that those investigations all were of similar length and about similar allegations.
And just when we say 12 investigations, I do want to flag each investigation is a bundle or is a bundle of up to 15 and sometimes slightly more than 15 complaints. So it's not 12 complaints, it's 12 investigation bundles.
Exactly, yes. And so what we found for those first two dates of investigation, the 5th and the 10th, for those investigations, and I will say those reports are not due yet, but for the investigations where tools were used, 7 of 8 already have completed reports. So those were completed about 1 to 2 months earlier than when it was due.
And when you say due, you're referring to the statutory timeline, which is that we're supposed to finish an investigation within 80 days of starting it.
Exactly.
So say 7 of 8 are completed, 80 days of June 5th hadn't happened by the time those were completed.
Exactly. Yes. Thank you, Anna. So we've already completed reports for 7 of 8 of those. And on average, the investigations were completed in 36 days. Important to remember that our clock starts at the same time yours does. So when we send out that initiation notice, that's when our clock starts as well. So when we say that these investigations were completed in an average of 36 days, that does include that 20-day lag time, I suppose, that 20-day initial time at the beginning. That's for the hospital to submit documents.
And we're not really able to do a lot in that 20-day period because we don't have the documents yet.
Yes, exactly. And so for investigations where the tools were not used, there were 4 of those, and none of them have completed investigation reports. Those ongoing investigations have lasted for an average of 61 days. That number, of course, is still going up because we haven't completed any of those investigations yet.
And so 41,
sorry, Anna.
That's 41 days after the documents had to be provided by the hospital.
Exactly. And all of those investigations have required multiple rounds of follow-up. So on average, the investigations where the tools were used, those are on average completed at least 25 days sooner than investigation where tools aren't used. We'll get that final count later when we have all of these investigations completed, but it does seem to have a significant effect on how long these investigations last. And we can already see that with how long, with how quickly the ones that use the investigation tools were completed and how long those other 4 are still going. So the investigation tools that we currently have is the Nurse Staffing Plan Approval Tool, the Professional Technical Staffing Plan Approval Tool, the Service Staffing Plan Approval Tool, the RN Staffing Levels Tool, the CNA Staffing Levels Tool, and the Mandatory Overtime Tool. We can go on to our next slide.
And I just want to flag the Mandatory Overtime Tool relates to nursing staff members. And there are, we know that there are some other areas where hospitals have reflected that, say, the nurse staffing or the RN staffing levels tool is maybe not not the best fit in an emergency department. We are aware of that, and we are considering an additional tool for that. But that's going to take some different work because an ED staffs so differently.
So we do have resources on our website explaining how to fill out the tool, who needs to fill out the tool, and just walks you through each page on it to let you know what sort of information we're looking for. And you can see those starred. So all of these tools, except I think the mandatory overtime tool, have a short video on our website.
Which means that the mandatory overtime tool will probably get a video very soon.
Indeed. We don't get a lot of those investigations. We've prioritized the ones that are used the most. So those investigation tools are also posted on the website. You can see on the left-hand side for nurse staffing with the blue stars, you would click that subpage for nurse staffing and then scroll down to investigation tools. And you can see CNA staffing, nurse staffing plan approval tool, and RN staffing during shifts tool. For professional technical staffing and service staffing, their pages both look very similar, but we're only showing the professional technical staffing for now. Right on, or at least on the slide, you can see it marked with that purple star that you would click professional technical staffing subheading, and then scroll down to investigation tools. That would be the same for service staffing. If you were to click on that subheading, you would then see the investigation tools related to service staffing on that page. And so now is the time of the webinar where we will be answering questions and answer, or doing question and answer session. Go ahead and send those questions to Tip, and that's again the all caps send questions here.
We are going to focus on the tools and the tool questions, but we do have some questions that are outside of that. So to the extent we can, we'll answer those. There is a question here about how to find work when you get past the 4th violation. And that is it stays at that same level. So if the 4th violation is $5,000, the 5th violation is $5,000, the 6th violation is $5,000. It just stays at that level. We also have a question about how can the requests be streamlined? And there are some ways to do this when you're working on tools. So if you're working on an approval tool, let's say for a med-surg staffing plan, and you complete that tool to talk about when the plan was approved on May 1st, that gets completed, it gets submitted, and then you get another and that gets submitted for a complaint about June 1st. Okay, you have your tool, you've completed it, and it says the staffing plan was approved for this unit on May 1st. 3 weeks down the road, you get a complaint about June 10th. You've already completed that tool. You can change the date of the complaint on top to June 10th and use the same tool you already filled out if you're talking about the same med-surg unit that was approved on May 1st. There's no reason for you to fill out the exact same information when you know what the approval date was and you've already completed the tool.
And I'll say too that for those approval tools, you don't even need to necessarily do it in response to an investigation. If you wanted to do this on the date that you're approving, you can do it on the date you approve, sign it, and then just change the date at the top.
Right, so you can have that as part of your staffing committee operations, that when you take a vote, you use this tool.
And I will say, we do have later on some a poll question that we can share, but right now we're doing questions and answers. We are wanting to get information about the hospitals from hospitals that have used the tools about barriers to those tools and possible improvements we can use, because we have heard that from a few different hospitals. So we are having conversations about that, and we are looking at ways to improve these.
We do have a question about transcribing the information into the tools is a burden, and is there a way we could create a standard meeting template? We generally do not create templates. I know we've just said that you can use the tool proactively, and you're welcome to do it. But generally, when we create templates then have to be used by everyone. And we know that different hospital systems have different ways of doing minutes. So we have not prescribed specific templates for that, but we do make the tool available.
I do see a question about what should direct care nurses submit. And I think part of that is getting to one of the reasons as well that we created the tools is to make sure that we keep this process transparent. We did hear concerns about how to involve direct care in these investigations. And so these investigation tools do have a section for direct care to sign off that, yes, the information does seem to accurately reflect the operations of either the nurse staffing committee or the unit. And so if we ask you to complete a tool, that's what we would expect direct care to be submitting. We wouldn't necessarily ask for any other documentation.
So we have a question about, is the same tool for nursing as well as non-nursing based departments? And what I would say is that the tool is the nurse staffing tool is or the nurse staffing plan approval tool is for units that have a nurse staffing plan. That may be a unit that clearly always has a nurse staffing plan, like Med-Surg. Or it may be for a unit that in some hospitals has a nurse staffing plan and in other hospitals doesn't have a nurse staffing plan, depending on the function of that hospital. So for example, the example I would use is an imaging department in a large hospital. An imaging department may have nursing staff assigned to that department at all times, and therefore would have a nurse staffing plan. Whereas in a critical access hospital, maybe there aren't nursing staff members assigned to the imaging department, and therefore nurses only go to that department with specific patients, and that wouldn't be a unit then that would have a nurse staffing plan. But the staffing plan approval tool is the same, because it's really looking for, was there a plan approved for this unit?
And I'll say too, for the situations where there isn't a plan approved for the unit, it's really just going to be a checkbox of no, there is no plan for this unit, and then to the signatures page.
We do have a question about whether there are caps on the fines. There are not. There
go ahead, Anna.
There are specific amounts for individual fines, but there is no total cap on the fines.
I see a question about how can we provide the best information possible for investigations. The tools are one way that can be very helpful to us, because that is the exact information that we need when we're doing any of these investigations. And if we don't see that clearly in any of the documents, that's when we usually have to go back and do follow-up. If there's any other sort of questions that we would have, again, we would do follow-up. And what we found often in the before times, before June 1st, 2025, before we had these investigation tools, the investigations that would often be more streamlined would have some sort of explanation with it, like some sort of cover letter or something that says these are the people who were working. This is you can find this information on this page with this report, this page with that report. This is what these documents are saying. Because again, there's 67 hospitals and all of you have several units and everyone does things a little bit differently and records look a little different at each hospital. So what seems familiar to you isn't familiar to us, and it does take that extra time for us to try to figure out what these documents are saying.
And Kimberly, when we're talking about that there are that many hospitals and they each have a different way, can you also give a number of how many investigations we're doing right now? Because I think it is kind of an astounding number.
Absolutely. We have, it's in the hundreds. Let me
900 this week.
I thought it might have gone higher than that. I think we might be in the thousands.
So that's 1,000 complaints. It was
since June 1st.
It was over 900 on Monday when I updated the website. So over 900 complaints that we are investigating right now.
Yes, and these are all complaints that we have received since June 1st. Yes, so that number did pass. I was right. That number did pass 1,000. We are at 1,035 complaints that are under investigation right now.
So and that doesn't include the complaints we have already completed.
Exactly. And we are starting complaints about 150 per week. And we do, just to help provide more context, our team is, for the investigation team, we have 6 surveyors. So those 1,035 complaints are being investigated by 6 people.
So we do understand that the tools are work for the hospitals. We understand that we're asking for a lot of information. We are asking for the information we need to make decisions and to determine what happened as quickly as we can in the way that's most efficient for everybody. We do know that when we send out these tools, we're asking for documentation, and we know that we're also asking for additional documents. We are well aware of that, and we're trying to ask for as little as possible and get the best information we can so that we can get these complaints investigated quickly.
And those tools, I will say too, were designed to gather the minimum information that we need when we are doing these investigations. So what you see on the tools, that's what we end up getting and what we end up looking for during any of these investigations. And so if it's not immediately clear in those documents, or if we're having to guess, that's when we're reaching out and asking for more documents and asking for more follow-up, which we know takes hospital staff time too to respond to those questions that we have.
We have a question about whether the direct care rep needs to sign the tools, and if they don't, will the tool be accepted? And what I would say is if it doesn't have both signatures, that's going to increase the likelihood that we need to do follow-up and ask additional questions. So we're not going to not look at the tool, but we'll probably end up having to do some follow-up.
I see that there's a question here of, is there any penalty for not using the tools if the required information is provided in an alternate format? I will say that there isn't a penalty
at this point.
But at this point, there isn't a penalty, but there is a risk. There is a risk that we, as Anna and I mentioned before, a lot of times these documents are not as clear as with the hospitals we've discussing as what it looks like to the hospitals, because the hospitals are there, they know their documents. Whereas we are coming into this and we're looking at the documents and from a pair of eyes that we're not at the meeting. And so if we see, for example, that you've had this plan that you voted on, but we can't find this person anywhere on your roster, and they don't appear to be a member. They appear to be a guest, and that roster was never updated. You run the risk of, based off the documentation that you provided, it looks like you didn't approve the plan because you didn't have equal numbers. You might have not had a quorum. So there's not a penalty at this time, but there is a risk.
I would also, I do want to clarify because Kimberly talked about a pair of eyes looking at the documents, and it's
multiple.
That's true. It's
Yep.
not just that we have one person gets the documents and looks at the documents and writes the report, and that's it. Do you want to describe what our review process is?
Absolutely. So when we get these documents, what we end up doing is we end up scheduling a team review. That team review for the nurse staffing plan will always involve me. And it involves the surveyor who is on that investigation, who is assigned to your lead, as well as other surveyors. If it's a nurse staffing plan that we've seen a few times, it's usually just me and the surveyor and any other surveyors who have previously as of recently been assigned to that hospital, or may soon be assigned to that hospital. And we'll go through it together, identify enforceable language. For the records, that is a mix of either a group of surveyors. It can sometimes involve myself, and this is just our initial reviews. We look through those documents, we say this is what we think it looks like. Then the surveyor will write up the report based off of the review of the staffing plan and of the records. And then that report ends up getting reviewed at this point by a compliance specialist before it goes to me. And the compliance specialist will check the surveyor's interpretations, make sure that, yes, that does seem consistent. That is what they're seeing as well. Then it goes to me for review, and then I do that same sort of check of, does this make sense? Yes, this is consistent. This is what we're seeing. And then sometimes, depending on which report it is, if there are additional questions or we want to get just another pair of eyes on it to make sure that, again, it is consistent and we are seeing the same things, if there's that extra level of complexity to it, we may end up elevating that to Anna for an additional review. It might go to the Department of Justice if we have any sort of questions on interpretation. So there's, when we say a pair of eyes on it, it's multiple pairs of eyes and multiple pairs of eyes at different stages of the process as well. And that's, again, to ensure we have consistency.
Kimberly, we have a question about when investigating mandatory overtime, why are no other records requested beside a timesheet? We could ask for other records, but we start with the timesheet.
We do have, oh, sorry, Anna.
Go ahead.
I was going to say, we do have a tool for that as well, but really what we need is that we need that timesheet to identify the underlying allegations of mandatory overtime. So mandatory overtime is really about one of 4 possible situations. Let's see if I have all of them memorized off the top of my head, Anna. Beyond an agreed upon and prearranged shift, more than 12 hours in a 24-hour period, more than 48 hours in any hospital-defined work week, with that meaning whether it's Sunday through Saturday or Monday through Sunday, however the hospital defines that week. And the last one is during the 10-hour rest period following the 12th hour worked in a 24-hour period. So these are all related to timekeeping, and these are all related to different timekeeping issues. And because of that, we really only need timekeeping records. The exception is if this is related to a call shift, then we're also looking at some of those call shift policies. We also developed that tool to look and streamline some of those questions we might otherwise have to ask about the mandatory overtime exceptions. So the if you worked for 1 hour or less, and it was due to the staff vacancy that became known at the end of the current shift for the next shift, or a risk of patient harm. And I do see there have been some questions asked about whether we can put that information into a slide. We do actually have a short video about mandatory overtime. So Tip, if you could end up putting that the link to the mandatory overtime videos, or even to the hospital staffing video page in the chat, so people can view that after our webinar. So that was a long answer of why we only need timekeeping.
And it isn't really only timekeeping, it's timekeeping and the tool.
Timekeeping and the tool is letting us get information about your call policies if it is a call shift, or about those mandatory overtime exceptions if one of those apply, which is really allowing us to reduce that back and forth and streamlines that information gathering process.
So we do have we have some variations on questions, and one of the questions is, why do direct care members have to sign the tools? The responsibility lies on the hospital, not the employee. And it's true, we hold the hospital responsible if there is non-compliance. But that said, we want this to be a process where we're gathering information from the best sources of information. So when we're looking for a tool that has the co-chairs of the staffing committee, it's because they're both the co-chairs. They both probably have some valuable information to give. If they do not agree, there are ways that we would handle that. If one co-chair says this is what happened and the other co-chair says no, it was like this, well, then we want to know that, because we'll probably have some follow-up questions. In the end, the responsible party is the hospital, but we're trying to get the best information we can to complete the investigation.
And that does also help with the transparency in that process, because Anna, we have heard concerns of, well, how are these investigations completed? How do you make sure that you're getting the full picture? And this has helped address some of those concerns that we've seen. So I see a question of, does the direct care representative that needs to sign the tools need to be on the staffing committee, or can it be any direct care person that the hospital chooses? It's going to depend on the tool. The expectation for any of these tools is that the people with the most knowledge about it are the ones who are signing off that, yes, the information appears correct. And so for the nurse staffing plan approval tool, that should be someone on the committee. So if the direct care co-chair is unavailable, they're on a much deserved vacation, that could be any other direct care member on the nurse staffing committee. If we're looking at some of those unit level tools, like the RN staffing level tool or the CNA staffing level tool, the expectation for those would be another direct care member on that unit who's familiar with those unit processes. So that could be, for example, a charge nurse who is familiar with how the unit operates, can sign off and say, yes, this looks correct for my recollection of what the staffing level was that day. Similarly, we focused on direct care there because that's what the question asked, but if the nurse manager is also on a well-deserved vacation, that could be a different nurse manager filling that out.
Similar to that question, we have a question about what is the expectation for a direct care rep participation in plan development, and I would say probably in tool completion, for a department that is contracted out to a different organization like dialysis. So if a hospital contracts with Fresenius or DaVita to provide the inpatient dialysis services. The hospital is still responsible for the patient care that occurs in that unit. So it would have a hospital nurse staffing plan for the staff in that unit, and may have a service staffing plan as well to cover the PCTs, the hemotechs that work in that unit. So with that in mind, a tool for that unit could be completed by somebody that on the direct care side who's not a hospital employee. If they're completing something talking about what was the staffing on that day in the unit, it could be that somebody who's not employed by the hospital, but who's one of these DaVita nurses, may have the best information to complete that tool along with the unit manager. In terms of the staffing plan approval tool, it would again be the co-chair or the co-chair's designee.
I see a question about documentation here and what sort of information is getting collected on the tools. There's a question that says, if it's clear that the complaint is related to not following the staffing plan, it seems that the break data is not necessarily if there's already that deviation, especially if both co-chairs agree. Is OHA considering a co-chair attestation in lieu of submitting extensive documentation? Also, is OHA considering asking clarifying questions on the complaint form to determine if break data needs to be submitted? And so what I'll say to that is that we are looking at opportunities to improve these, and we're gathering feedback now. I've seen that there are some other questions in here as well that have been providing feedback on the tools. And we're taking all of that into consideration. We're having conversations with these hospitals as well that have expressed concerns to us about the tools. And so we're taking all of that information. We want to make something that works for all parties involved in this.
We also had the Nurse Staffing Advisory Board give input at their last meeting at the end of July, and we'll continue in our conversations with them to get their feedback.
Anna, do you think now would be a good time for us to do that poll as a maybe a break in the questions?
Yeah.
Okay, so we do have a poll for all of you about those tools with the formats that you would prefer. So let me see if I can get this started. Okay. So you should all see that on your screen, and it's going to ask you to indicate your preference on the format for those tools. All right, it looks like about half of the people have responded, so we'll give you maybe about 1 more minute to respond.
And while we're doing that, one of the questions we got was actually, why could we use our own tools instead of these? Do we need to use this format? And what I would say is, if you have this, you know, if you've created this exact thing as a Word document, we'll take that. The issue is, if you've created something that's kind of similar, chances are it's got your version of questions and your version of how you answer those questions, and we're going to end up still asking, what do you mean by this?
All right, so I will be closing that poll right now. Thank you everyone who participated. Okay. So we have that, and I will make sure that that gets downloaded so that we can keep a record of it. Thank you, everyone. All right.
We do also have a follow-up question on the dialysis about whether OHA has guidance about whether inpatient dialysis would fall into a minimum statutory ratio category. That's an interesting question, and I'm going to have to go with it depends, and here's why. The statutory ratios are listed in ORS 441-765, and it lays out specific units. Dialysis is not listed as a unit within that. So the units that don't have a 441-765 ratio are psychiatric units and units listed in 441-766. For units that don't have a statutory ratio, it's up to the hospital staffing committee to come up with a staffing plan that includes either ratios or minimums for staffing in that unit. Now, inpatient dialysis can happen in a hospital in a specific designated space within the hospital that is only used for dialysis. So in that situation, that isn't a unit that's named in 765, so it doesn't have a ratio, right? But I know in some situations and in some hospitals, depending on a variety of factors, the dialysis may actually occur in the patient's room, and they'll just bring the equipment directly to the patient. The patient is in whatever unit they're in, be it med surg or oncology, and the patient is dialyzed in their regular inpatient room. So in that situation, if that hospital were using the statutory ratios, it could be, this is a could be that the statutory ratio would apply, but it could be that if there's a staffing plan in that unit, the staffing plan may have some sort of exception that says, well, the ratio is usually this, but when a patient is on dialysis, the ratio changes for a patient who is actively being dialyzed. So there isn't a minimum statutory ratio that says dialysis. There are times when a ratio may or may not apply.
And ultimately, when we do these investigations, we're looking for a unit that has an approved nurse staffing plan. We're looking at the enforceable language in that nurse staffing plan.
So we have a question about whether hospitals can get an extension on investigation documents on that 20-day timeline. The statute doesn't give us any authority to grant extensions. So that is, we don't have the authority to give extensions. I will note it's the hospital administration as a whole that is responsible for providing those documents. So it's not necessarily a single person.
And if a hospital were ever to find itself in that sort of situation, we would encourage you to reach out, and we'll let you know who else would be able to sign off on the tool.
I'm gonna jump because we are coming towards the end of our time. I'm gonna jump to we can continue answering questions, but I do want to flag that we will have 2 additional webinars that we are planning on at this point. The next one will be about specifically the changes that happened in HB 3294, which passed in the legislature this year and made some very specific changes to the hospital staffing law. So we'll go over those, and we'll have that webinar in September. And then after that, we are going to be planning one that is about quorum and equal voting. And it will have some Q&A time for that. In the meantime, there is a quorum and equal voting hospital staffing short. So we already have a short video about that topic that's available on our website.
Yes, that is, and we've talked to the Nurse Staffing Advisory Board about this. That is the one of those requirements that seems to find hospitals by surprise, the quorum and equal voting. So we are answering any and all questions that people have about that.
And just a reminder, our website is healthoregon.org/hospital staffing. And if you go to that page, you'll be able to see we have specific pages for nurse staffing, professional technical staffing, and service staffing. We also have the page where we post all of those staffing plans that are submitted to us. And we have a page of the videos, and we have a page where we post all of the investigation reports. So all the reports that we've already completed are available online, and we post those pretty quickly. So you can always check and read not just what's happening at your hospital, but at other hospitals. And I know that there are some staffing committees that have folks who make a habit of reading those reports to get information about what compliance looks like.
And those investigation reports do indicate the information and the documents that we rely on when we're making that determination of compliance and non-compliance. It's a pretty good record of showing what happened during an investigation.
We have a question about whether there are specific differences for non-union hospitals. The differences for non-union hospitals ends up being in the process for selecting staffing committee members. But from an investigation standpoint, from the work that we do, there isn't a difference. And certainly from a compliance standpoint, in terms of what the violations are, they are the same for union and non-union settings.
And we would still request that the tools get completed at union hospitals, at non-union hospitals, because that, again, is meant to streamline the process, to reduce the need for that additional follow-up, and to simplify some of those situations that initially look like they might have added complexities.
And I would add that the direct care individuals who are completing those tools, it's not based on union membership or non-union membership. It's based on role in the unit or role on the staffing committee. Okay, so with that, we want to thank you for participating, for all the great questions, and for also the answers in the poll. We are still gathering information, and we do want to hear from you because these investigations we know are a lot of work for the hospitals, and we know for some hospitals there are a lot of investigations happening. So we would like to do this in a way that's efficient for both the hospitals and the OHA. And with that, we're going to go ahead and wrap up. And we will be posting this on the website and we'll send it out on the listserv as well for folks who were not able to join in person.
Thank you, everyone.